Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña.
Welcome back to EM Pulse.
Sarah's, it's summertime, so I think we should talk about something sunny, like oncological emergencies.
Okay, not super sunny, but definitely important. There are 16 million Americans living with cancer who account for approximately 4 million visits to emergency departments each year. Patients with advanced cancer, especially older patients, are particularly vulnerable to emergencies. And to improve our recognition and response to oncological emergencies, we are talking today with a friend of mine who is actually an oncological emergency physician.
That is a crazy job. And to be clear, she is a physician who only sees adult cancer patients in the emergency department. So while some of these principles apply, we're only talking about adults today.
But that gives us the opportunity to do a follow-up on kids.
I like that. That's a great idea.
So, Monica, I want to start where most of us in the ED initially interact with cancer, which is making that potential diagnosis. And we all know that ideally cancer is caught early with subtle signs in clinic or screening through the primary care physician. But there's been a decrease in access to primary care, and not everyone gets that screening that they should. So we are often the first line. What types of cancer are most likely to be diagnosed in the ED?
I would say the most common cancers would be breast, colon, and lung. And studies have shown that it's probably around the range of 20 to 50% of diagnoses for these specific malignancies are actually through the emergency department.
That's a lot. Yeah, for sure. I would not have expected that. You know, I think sometimes we struggle with our role in that diagnosis of cancer in the emergency department. Monica, what do you see as the role of the ED physician in that initial discussion and diagnosis in the emergency department?
I think that we have a very, very vital role to play, and a role that maybe we had not initially thought of when we were in residency training. A lot of times when we are thinking of cancer patients coming to the emergency department, they might be symptomatic from something. But I want to take a step back and talk about just, incidental findings. So it's these patients that are actually common as well, where you do a CT scan for something else, and then, maybe a trauma, and then you find incidental findings. In an emergency medicine physician's mind, an incidental finding that's not compressing something, that's not making someone sick at the time, might just be out of sight, out of mind. And I know they did a study showing, how many times these quote unquote incidentalomas were actually put on discharge diagnoses. And it was really low, like 27%. And it's important to realize that even though we are, the acute emergentologists, these are also important as well. So if you don't mention it to your patient who at baseline probably doesn't even really have a good understanding potentially of medical conditions, that's where we can fail really bad as emergency medicine physicians. I want to have us think of ourselves as not just isolated, doc in a box, this is my shop, but we are a part of a great continuum. And fortunately or unfortunately, like you said, we will probably be the first providers to actually see and potentially diagnose cancer, whether we like it or not.
I think that's a really important point, and that communication is very key in all of this. Monica, kind of walk us through a conversation discussing that newfound potential for cancer with a patient. Like, what are the components that we need to communicate to our patients?
There are a few main things that patients want to hear. The first thing they'll ask is it cancer? And the thing is, I don't want to say that we shouldn't be throwing out the word malignancy or cancer to these patients, because sometimes being direct is important. But since we're not oncologists, and since sometimes findings that look like potential malignancies actually aren't, it's really important to be sensitive about this. And so what I like to say is, I have found on said CT scan something that is suspicious, that really needs close follow-up. And then I can give a few things, like it might be a concern for infection, it might be cancer, it might be a lot of things. And the reason that I want you to follow up closely is that I don't know what it is, but we need to work it up further. And so it gives the patients an idea of why they need to follow up soon, but it doesn't lock in a diagnosis. And I think that's really important because we at MD Anderson get referrals for a lot of possible cancers, and the patients have been told, that it's cancer, and then we have a suspicion of cancer clinic, and after biopsy, it actually isn't. And so they went through like 2 months of anxiety when it was something else.
Yeah, I think that's why I asked that question, because in the emergency department, pre-biopsy, minimal labs, not a specialist, I struggle with putting that big C out there, and that is really a fork in a road for so many patients and families, that changes the way that they live their lives and think about their future. And so, but you also want them to take it seriously. And so that balance is really tough. But I think it is important to give a gravity to that conversation so that they get the proper follow-up.
Yeah, I've been in too many of these where I am unfortunately giving some news of a new finding that's concerning for cancer. So how do you decide which of these findings might be concerning enough to warrant an admit today for an expedited workup versus follow-up in suspicion for cancer clinic?
It really is practice specific because you have to take into account the patient, your practice environment, and availability of the oncologist for you to even discuss these cases with. Because I know a lot of our colleagues, they probably can't pick up a phone and talk to an oncologist. And so do you trust that they will follow up? Because that's really important too. Do they have the wherewithal and the resources to be able to, say, hey, in 2 weeks, I want you to go to follow up at this clinic appointment. If they can't even make it to that appointment, if they don't have a ride, things like that, that's going to be a really big issue. So patient-specific factors is number one. Number two, what type of practice environment are you in? Do you routinely actually get close follow-up? Because you can put these follow-ups in on their dispositions, but how long is the turnaround time? That's something important to think about too. And so the third thing that I think is easier for us as emergency physicians, so if you take out all of these other factors, just seeing where these masses are or what potential issues might happen will be important as well. Because pain is a huge reason why patients return to the emergency department. So a mass might not be in a specific area that might be compressing something, or, your labs might not be showing, an anemia that is borderline needing transfusion, but not yet. So subtle things might actually be even bigger reasons why you would want to have closer follow-up or even admit. And I wanted to just highlight cancer pain as one of them because in the general patient population, there's been a pull towards, not wanting to prescribe too much opiates and really being very cautious. And while you still have to be cautious in the cancer patient population, pain is real, and the amount that we usually prescribe for the general patient population will not be sufficient. So if a patient came to you for abdominal pain with their newly diagnosed colon cancer and, you want to discharge them home with pain medication, 10 pills is not going to be enough. It's not going to even get them through, the first 2 days sometimes. And so having that idea of the subtle things or the not so medically catastrophic diagnoses might actually be the reasons for repeat emergency medicine visits is going to be important.
Yeah, and I want to come back and talk about pain a little later, but as an ER physician, as you mentioned, there are some emergent things that we need to know about. So what are some of these emergent conditions that are specific to patients with cancer that we should be aware of?
There's a few studies that take a look at the most common visits for patients with cancer visiting the ED, and some of them include pneumonia, gastroenteritis, fever, abdominal pain, and ileus. And so all of these conditions, as emergency medicine physicians, we are trained to recognize, but everything in the cancer patient population is just more subtle the way it presents. Lung cancer is a fairly common diagnosis in the emergency department, and I wanted to use the lung cancer patient as a case. So they basically will come in about, it encompasses about 10 to 12% of cancer-related emergency department visits in overall, and the admission rate is 66%. And so with this type of cancer, what you're going to be seeing is, besides fever, respiratory symptoms, so worsening effusions, along with neurologic issues. Other things to think about are subtle presentations like just feeling fatigued can also indicate electrolyte abnormalities or anemias, things like that as well.
Can you speak to the neurological issues? Like, what do you mean by that specifically, Monica?
Sure. So, unfortunately, a lot of times patients present to the emergency department for the first time for their first diagnosis, and they were previously well. And they might have had just, subtle symptoms, but neurologic findings that does indicate that there might be a metastasis to the brain. And when you think of patients that come to the emergency department, a lot of times it's for acute issues. And so that's one of the reasons why they would present either seizure activity, really bad headaches, and unfortunately, sometimes even altered levels of consciousness due to cerebral edema from metastases.
So really any subtle neuro-based symptom or sign should be taken seriously in our patients that have cancer. Like we should really slow our roll and stop and think about it. Is that fair to say?
I think it's such an important thing to highlight, even with trainees that come to the emergency department. When you think of the pathognomonic findings for certain things like cord compression as an example, you want to actually catch things before you find these lower motor neuron symptoms. You want to catch things before there is a problem that potentially can't be reversed. And so just presenting with pain. A lot of times these patients have had back pain for a really, really long time. And they have either seen their primary care doctor, maybe they've gone through other emergency departments. You want to be able to catch that metastasis at that time with early cord compressions that you don't find I call it the end symptoms, because once you have an end symptom, it's harder for radiation oncologists or neurosurgeons to really interact with things and make them better.
So, Monica, I feel like one of the other common things I see in the ED, often with the initial presentation of cancer, or sometimes the way we find the cancer, is DVT or PE. So, they come in and we end up diagnosing that. And then through some of those studies, we end up also finding a potential malignancy. Is there a different way that you would treat DVT or PE in a patient that you also had a concern for new cancer? Is that something that would warrant admission, or how do you approach that?
So at MD Anderson, we have our own algorithm, and a lot of people are surprised because we send a lot of patients home. Not all DVT or PEs require admission, and so there is risk stratification. Are they symptomatic when they're ambulating? Do they desaturate? Do they get tachycardic? Even on CT, if it's a pulmonary embolism, is there evidence of right heart strain or, with bedside ultrasound? And so if you are in a intermediate to higher risk, it does warrant some observation or admission. But a lot of these times, DVTs and PEs can be found incidentally, and a lot of these patients can be sent home. The big things that I will always ask is there a bleeding risk? And then also, sometimes these patients have not had any imaging of the brain to make sure that there's a metastasis. And so I ask questions that might indicate that there might be something neurologic, like headaches, vision changes, stuff like that. Also, certain cancers just tend to bleed more. And so I'm more cautious. Like melanoma, I am more cautious to prescribe anticoagulation to these patients because when they're on it, if they do have an intracranial metastasis, it bleeds. And it's pretty bad when it does.
Monica, once patients are started on their appropriate therapies, radiation, chemotherapy, resection, whatever it might be, there are way too many complications to all of those interventions to hit all of them today. But if we're just kind of to break it down as to what are some of the common things we see about, one of the ones that I feel like we run into a lot, maybe you can tell us the data on that, is febrile neutropenia. Okay, so what is the latest approach to these patients? Like, how fast do we need to get antibiotics in? What labs do we need? What is our dispo on those patients? Walk us through febrile neutropenia.
There's a lot of data that is showing that the sooner you get antibiotics into these patients, the better. And so there's a lot of metrics, even at our institution. Once they hit triage, that's when the time starts. And so it almost is like treating a patient with STEMI or a stroke. So the clock starts and you really need to be getting antibiotics into these patients within the hour, ideally 30 minutes. And I do want to just add a little caveat for antibiotics, because a lot of times we think antibiotics, they need vancomycin and a broad-spectrum beta-lactam antibiotic. And so I see a lot of times everyone does the combination, but you actually only need one. You only need to add your broad-spectrum beta-lactam antibiotic. And so monotherapy that has your anti-pseudomonal activity like cefepime is fine. You don't need to add the vancomycin unless you suspect MRSA. But the time that you initiate antibiotic administration really does matter. I think they did a study where they basically looked and saw what the mortality risks were. And basically, if you get antibiotics in before 60 minutes, the decrease is actually significant. And for each hour of delay that you have, it increases your risk by 18%. Now, on the other side, a lot of colleagues, when they come to MD Anderson, are surprised at how many people we discharge. And the goal is trending towards trying to transition them to home sooner in a certain subset of patient population. Also, febrile neutropenia is not treated the same with hematological malignancies like lymphoma, leukemia, myeloma as solid tumors. So solid tumors, depending on if the patient is able to follow up, if they live within, for us, I think it's like a 30-minute radius, we can actually discharge them home if they're reliable. And so we do an outpatient neutropenic follow-up for patients that if we actually work them up in the emergency department and they don't have a source of infection, we can send home. If they're reliable, take their antibiotics, if they can come back for their repeat labs as well.
Solid tumors.
Yeah, solid tumors. For liquid tumors, that's not the case. The liquid tumors, they get admitted because they just have a higher risk for morbidity and mortality. And the way that you can determine for solid tumors, in the emergency department, they do have a MASC score. And so MASC stands for Multinational Association for Supportive Care in Cancer. And it's an index score that basically, when you apply to the onset of fever and take a look at the criteria, if the score is less than 21 points, there's a low risk for mortality, and you can consider sending them home.
What do you recommend? Do you give a dose of ceftriaxone for those patients that you discharge so that you have that kind of depot effect and lasting 24 hours, Monica? Or do you just go with that dose of cefepime when you're discharging the patients that can go home?
So how we would do it is, if you're not neutropenic and if there's no fever source, you might not actually get sent home on antibiotic, especially with a lot of these, viral respiratory illnesses that are going around that sometimes the viral panels don't check. So the patients that are potentially okay to send home would be solid tumor patients that do not have a source of infection found on your workup. The source being when you do a chest x-ray to look for pneumonia, along with a urinalysis to make sure that there's no urinary tract infection. I will put a caveat in for the respiratory infections, because if the patient is symptomatic enough, it might warrant observation, even though there isn't an antibiotic or a treatment that you need to give. But for the patients that are well appearing, at MD Anderson, we have a outpatient neutropenic fever pathway, and there are some criteria. So the patient has to live within an hour away from our institution, as well as be reliable to be able to come back for further workup and be able to tolerate orals, to take oral antibiotics, and also have someone with them to monitor things. And if you are going to send these patients home, then the antibiotic choice, you give them two. First-line therapy can be ciprofloxacin, 750 milligrams PO twice daily, plus amoxicillin/clavulanic acid. And that is for 7 days. And if there is a documented, really serious beta-lactam allergy, what you can do is ciprofloxacin and clindamycin, 600 milligrams PO 3 times a day for 7 days.
So, Monica, talk to me about tumor lysis syndrome. When should we be looking for that in the ED, and what kind of workup should we be doing?
With tumor lysis syndrome, you have tumors that are high risk, that have high risk tumor burden. So think of your advanced Burkitt lymphoma, advanced leukemias, or even your early diagnosis of leukemia. So liquid tumors. And then you can get it sometimes in the solid cancers, but think more of when the patients are receiving treatment, because usually with tumor lysis syndrome for lymphomas and leukemias, it's pre-treatment with the solid tumors, you think of it after post-treatment when the tumors are lysing. But the thing that I want to share, and again, I keep on saying this over and over again, is subtlety. Because you want to catch things early on. Most of these patients, if they are solid tumors, they will have had labs previously. And so there's grading criteria for tumor lysis syndrome. And so on your lab values, they might not be super high, but the trend has been higher. And these oncologist teams, they definitely take that seriously. And in our institution, will actually put an observation or admit for early tumor lysis syndrome. There are lab values that normally we don't routinely get as emergency medicine physicians. And so if you are suspecting that you have a patient that presented with fatigue, a possible new leukemia, you need to add these labs on, such as uric acid and LDH. I think those are the two main ones that we don't think about that are important. But with tumor lysis syndrome, you have laboratory criteria and clinical. And for us, really, clinical, it's all about trends. So if the clinical TLS is like increased serum creatinine, 1.5 times upper limit of normal. So that's easy for us to look at. But then the other criteria is like cardiac arrhythmias or sudden death and seizures. These are end stage things. So I don't want to, put on my diagnosis clinical TLS. That means that potentially we missed it multiple other times. And so that's why I wanted to just kind of put in a plug for making sure to look at trends instead of just the actual laboratory or clinical, because catching things early is important.
Are there any specific symptoms that might tip you off to be looking for tumor lysis syndrome?
That's the problem. Everything is subtle when you think about oncologic emergencies. For tumor lysis, it might just be fatigue. It just might be some decreased PO intake and decreased urination. And so being able to pick up on these subtle signs, I think, is important, because we're taught to look for, bigger findings. Even on our EM boards, it's these big findings, but it's the subtlety that I think is the most important to remember. That once you see patients that present with your altered mental status, with, your arrhythmias, that's a bit late, or a lot late.
Mucositis. I hate to see a child come into the emergency department with mucositis. Talk to us about which groups are at highest risk for mucositis. And then I think we can all kind of visually see that diagnosis, but what can we do to help our patients with mucositis?
I think patients receiving radiation to the head and neck are really at most risk, because it's not just the pain, but it's also being able to hydrate. And so with the dehydration, everything gets worse as well. And so I want to put in a plug to get specialists on board early if you have the resources. I think that's the most important thing, because mucositis is not going to go away. A lot of times these regimens for radiation, it's multiple times. And so someone needs to be following up to make sure that the symptoms are improving and to catch things early. A lot of times patients might need hydration, hopefully not in the emergency department, but it can be set up as an outpatient. And so we have our palliative care services that help with symptom management, and getting them on board early, not at end of life, is going to be the most important, because I have a few medications that I can prescribe for mucositis in my toolbox, but really it's the follow-up. So if I discharge you on this medication in 3 days, did it help? And if it didn't, having someone in the outpatient setting be able to work with that patient so that they don't come back to the emergency department even worse than before is going to be the most important thing.
What medications do you usually prescribe for somebody who has mucositis?
So you can do topical mouthwashes and rinses for mucositis treatment. There isn't a one-size-fits-all approach. So sometimes viscous lidocaine might help as well. But personally for me, I'm not as successful in mucositis treatment. That's why it's one of the things that I actually get my palliative care colleagues on board early, because it is very, very difficult to treat. Things that you shouldn't use, I think, I just wanted to highlight as well. Sucralfate isn't as helpful for radiation-induced oral mucositis. And then another thing is sometimes you will need to use systemic analgesics, like oral opiates. That's something for us that we use quite commonly. It doesn't target specifically the area, but it does help as well. And so doing a topical mouthwash or rinse and then giving an oral analgesic is something that I usually do in the emergency department.
Another very common thing that patients come in with, especially those who are currently in treatment, they are coming in with nausea or vomiting, and they've already tried whatever they have at home and they still can't keep anything down. So they end up coming to the ED. Do you have any recommendations for approaching treatment for these patients?
Nausea and vomiting is notoriously difficult to treat. I think education is important because sometimes you think that the patient has failed their medications, but they weren't educated to take something around the clock, or they didn't have like a first line and a second line agent that you could alternate as well. We have an observation unit because sometimes even with the best intentions and the patients have tried their best, it just doesn't work. And so making sure that you have a low threshold to actually observe or admit these patients is important too, because getting dehydrated and not being able to tolerate PO also has its issues and things can go downhill really fast. Consider observing them for some prolonged IV fluid hydration because a lot of times there's no overnight magical pill that'll make things better.
And is ondansetron your go-to antiemetic? I have generally been taught that oncologic patients often get very high doses of ondansetron. So what is your threshold? How high do you go in terms of dosing? And are you getting EKGs to check their QTC?
A lot of our patients have EKGs already, but if they don't, prior to starting Zofran, I actually will get an EKG just to get a good baseline. Because to be honest, most of the antiemetics cause some sort of like QTC prolongation. There's always these side effects that we need to just make sure at baseline we're not making anything worse. Zofran is our go-to. It's even on our order sets. I don't know how high you guys do for a regular because I haven't seen a regular, quote unquote, like a regular patient in the general population, but we start off with 8 milligrams. We don't really keep on trying the same medication once 8 milligrams doesn't work because there's many different types that you can use. And so using a different medication as a second line is what what we do at MD Anderson. So if Zofran 8 milligrams didn't work at that time, then we'll switch to something different.
What about chemotherapy-induced diarrhea? How do we help those patients that are having profuse diarrhea?
I sound like a broken record. Everything is subtle. Even if the patient isn't having explosive diarrhea, sometimes they're really embarrassed to say how many times, but ask how many times. This is a story that I had when I was a fellow. I said, how many times have you been having diarrhea? Only once. But it basically was a constant leak the whole day. So that's pretty bad, isn't it? But it's important to know that patients receiving chemotherapy treatments and other therapies, when they start having diarrhea, they're just more frail. And so have a lower threshold to actually, this is why I sound like a broken record, observe the patient or admit them for IV hydration. Also, it's important to find out why they're having the diarrhea. We like to think most common things are common. And so we'll be the first to say, okay, it's just due to chemotherapy. But in this patient population, I think it's important to also make sure that our first thought for diagnosis is actually true. So sending stool studies, making sure that it's not due to colitis, because cancer therapeutics have changed dramatically over the last 10 years. So when you say someone's on chemotherapy, the first thing that comes to mind in my head is, are they only on chemotherapy? Or have they had a treatment prior and then they're back on chemotherapy? Or are they on chemotherapy planning for another different treatment? Because it changes things. A lot of times chemotherapies now are used in conjunction with immune checkpoint inhibitors, other treatments. And so when you say chemotherapy-related diarrhea, it could actually potentially mean an immune checkpoint inhibitor diarrhea. And there's grading scales for that and treatments that need to be followed if it's due to that. And so if the patient has been on immune checkpoint inhibitors, do a CT scan. If you find colitis, that is also concerning. Other labs for immune checkpoint inhibitors would be ESR, CRP, checking if other body systems are affected, like adding a TSH on, because that's usually silent too. So doing more of a workup than what you would normally do is going to be the most important for these patients, even with chemotherapy-induced diarrhea. Make sure it's not C. diff. A lot of times these patients have had antibiotic usage prior. It's kind of a big black box of maybes.
The next thing I wanted to get to is anemia and thrombocytopenia, because I know that this may be managed differently in our oncologic patients than in our patients without cancer.
For us, if the patient has hemoglobin below 8, then we routinely transfuse, but most of our patients are walking around with hemoglobins less than 12, for sure. Platelets will be less than 15 transfuse. That's our criteria.
Monica, some of our patients come through with radiation specifically as a treatment modality. What are some of the complications that are specific to radiation interventions?
So it depends on the area that's being radiated, but we already talked about mucositis or having malabsorption symptoms, diarrheas. If you're getting it to your thoracic area, having pneumonitis. And pneumonitis is a little bit difficult because it can present with a lot of symptoms that are similar to pneumonias. So those are some of the common things that you will see with patients with radiation. I also want to say with patients with radiation, you have acute symptoms, but also don't forget about chronic symptoms. And so a lot of times in the emergency department, we always think about, what brings you to the emergency department? And your time to present illness is, in the last 2 weeks or 3 weeks. And you don't think that certain things that happened maybe a year or 2 years prior could be the reason for that. Radiation side effects, there's a lot of chronic complications too, like diarrhea and malabsorption and pneumonitis as well, that can present long-term. It's a reason for patients to represent to the emergency department too, for the chronic complications.
Communication with the patient is key. When you find something that might be cancer, please tell the patient. Put it on the discharge summary and help with the follow-up. But don't lock in the diagnosis.
Febrile neutropenia. Antibiotics need to be given within 1 hour of hitting triage, ideally within 30 minutes. Treat with cefepime and vancomycin if you suspect MRSA. Standardize with order sets and policies and set up discharge and admit criteria with your colleagues.
When it comes to tumor lysis syndrome, it is important to look at trends, not just the current values. You may catch it early if the values are trending up.
Mucositis is tricky to treat and worth involving specialists for treatment and disposition.
Nausea and vomiting can be a sign of something greater. Dehydration can be problematic and hard to treat, so consider admitting for IV fluids and figuring out why we have the nausea and vomiting. You can use Zofran 8 milligrams right off the bat. If it doesn't work the first time, though, move on.
Just like vomiting, diarrhea can also be a symptom of a more complicated diagnosis. Consider IV fluids and observation.
Most of these patients have abnormal platelets and hemoglobin levels. Refer to your local policy, but a good baseline is to transfuse RBCs for hemoglobin less than 8 and platelets less than 15,000.
Remember that any neurologic symptom in a patient with cancer can be a sign of something more serious and often requires further workup. Don't blow these off.
Okay, that was a lot, but there's still more to come because this is a big topic. And as we now know, one that people do entire fellowships about.
So join us next time for part 2 when we talk about pain management, goals of care in the ED, and a few ethical dilemmas.
Thank you to our department for doing process improvement projects to improve the care of this population of patients.
And thank you to OM Productions for improving our production quality.
Until next time, stay curious, stay inspired, and stay tuned.